said good morning, everybody. Much better, thank you. Today, we have our sponsors, a lot of them. We have 14 companies that sponsor today's program. We have Sandoz and Novartis, Memorial Healthcare, Viatris. They are our primary sponsors. Let's give them a round of applause. We had our community sponsors, TG Therapeutics, Mavenclad, Octave, FlowMed. Again, a round of applause, please. For everybody I did not mention, they're exhibitors, they're not sponsors, so I can't say their name because if they want it said, they got to become a sponsor. That's all. Just the next level up, guys, all right? Our next presenter. Again, you could see her information in the journal, or I can read a little bit to you. Her name is Dr. Buse Sengul, and she is the MS neurologist at the Memorial Neuroscience Institute in Hollywood. She specializes in caring for patients with multiple sclerosis and neuroimmunologic disorders such as neuromyelitis optica, stiff person syndrome, the next one I can't even say. Then we'll go to acute disseminated encephalitis and transverse myelitis, as well as multiple sclerosis. Dr. Sengul states, I was always interested in biology and human physiology, which drove me to attend medical school. During a research project, I shadowed a physician in multiple sclerosis at a multiple sclerosis clinic and saw firsthand how the disease affected patients day to day in their daily lives. And so let's welcome Dr. Sengul.
Well, good afternoon, everyone. Thank you very much for the kind introduction, Stuart. It's so nice to be here. I'm seeing very familiar faces when I look at you, so nice to see all of you. And so today my task is very simple, I guess, and this is of course sarcastic, but we are going to talk about disease-modifying therapies with multiple sclerosis, what we deal with every single day. And this will be a conversation, and if you are a patient of mine, this is probably not the first time that you are going to hear this lecture, and so that's why you will be very familiar with the things that we will talk about. And I would like to keep this as conversation as possible, give you, again, exactly what I typically tell my patients in the clinic settings, and tell you a little bit about what we are expecting, especially in near future, and this is really a bright time or good time to discuss about these medications, because I really think that future is going to bring us so many options. So I have got very limited amount of time. That's why I will try to go through medications very quickly and give you little tidbits. But if there's any questions, of course, please make sure to ask. So just talk about multiple sclerosis clinical course. And this is something that we are probably not going to use for a long time, but when we diagnose a patient with multiple sclerosis, and I'm assuming many of you might live with MS or you love somebody with MS, so you are already familiar with this. So many of my patients come and say, what type of MS do I have? And now we do recognize, while we do tell you different types, we do recognize that this is much more of a spectrum. When we first diagnose you, we typically tell you, I mean, this is for progressive relapsing patients, not progressing patients, we typically tell you that you have got relapsing remitting disease. And especially, let's say that without any treatments or anything, we expect you to have relapses. And those relapses are typically loss of function. That can be your visual function, that can be your sensory function, that can be your motor function, such as weakness, and that you typically gain it back, but when you gain it back, it might not be 100% back, right? So looking at this graph, you see a patient that has relapses, and after those relapses, the symptoms or the functional level might not get completely back to normal. It's not a flat line after the relapses. And as you know, after a while, we don't necessarily see those relapses as much, but despite the relapses are not there, there's a progression. So as you know, there are so many medications, and we really thought that when we get rid of relapses, this would be a completely flat line. and we would keep you here, keep you without any progression. But what we are really seeing is this. So if you look at the course or the blue line there, the line in the, I don't know if the color is really visual there, but let's assume that this is a patient that has 2 relapses. Lost their visual function, gained it completely back, then started to have some numbness that might or might not come back. And we wanted to see those patients as exactly that flat line. But what we actually saw is that there's still some level of progression. And that's what we really need in the pharma world or research world right now. How can we get that line back to the blue line? This is still much better. Look at the faint line. This is what would have happened without the medication. So that functional level, decrease in the functional level or disability, we could even see much worse. But now with the medications, we are really able to lower it down. That's why I really truly believe in medications, and that's why we are talking about it. But it's not truly my topic, but I will say that I also do believe in lifestyle modification. If you see me in the clinic, I will tell you, you gotta exercise, you gotta eat healthy, you gotta really take care of yourself. This is all your full wellness, your mental health, your physical health, and that will really help you. Because unfortunately, we don't really have anything else to give you, like a magic pill that will keep you the same still, but the rest of the things that you can really do to help yourself. So many of you have lived with this disease for a long time, even maybe longer than I had been in this world. And you know from where we came, and there were days that we only could offer the patients steroids or, like IVIG, plasma exchange, etc. And then we started to have medications, and those medications were good, okay, but there was so much time period that patients couldn't even get on them because they had to win a lottery to get on them, right? And then we got better. We could offer those medications to the patients, but there were some side effects. There were problems with them. And then what happened? We came up with oral pills. And after oral pills, we came up with infusions. And now we have got treatments that you might not even need to use day-to-day basis. So this graph, this is from a paper that was a review paper from 2018. And we even know what happened in the last 6 years, that we had more and more medications. This is just, there's no updated version of this, and it's a good visual, so I didn't want to kill it myself by updating, but this is just so hopeful. And that's what I like this, that this is going to show that in the future, hopefully, like when somebody updates this, we are really going to have even more options to be able to help you. So this is a very busy slide, but I don't want you to read all of them. I will go over them, but this is just something that actually I give to my trainees to talk about the medications and what the patients need to be doing, what type of treatment they are, and how if the patient wants to get pregnant or they want to focus on that, what can we do if this is a good treatment or not, and what are the blood testing that we want to have. So I wanted to show you what I typically teach my trainees and what we also talk about in the clinic. Okay, so going forward, we are first going to go a little bit historical classification. So we are going to talk about the injections first. But as you know, there are some outliers in the treatment. So we will talk about injections, oral treatments, infusions, then we will talk about a little bit about them again. But also, instead of just classifying the medications as injectables, oral treatments, and infusions, I wanted to point out immunomodulators, and then we will talk about this a little bit more. So what does this mean? Immunomodulators are going to be the treatments that will make some changes on your immune system, and this can be a major change or a milder change, and those changes are going to be the reason that your MS is going to be under control. So especially with the injections, and you will see that the last one, Kesimpta ofatumumab, is a little bit on the italic because I'm actually, while it's an injection, I'm excluding this with the things that I will be talking about because it truly belongs to a different class of medications. But these injections, majority of the time, they are older treatments. These are interferons or glatiramer or Copaxone as the old brand name. And these are the treatments that we first had, and I'm so glad that they were in the market when we needed them, but right now they are not the most efficacious treatments. However, you might still be on them. If you are very stable, you had been stable, your physician might have kept you stable on them, and that is completely fine. Or there could have been another reason, potentially a safety reason, that your doctor did not want to put you on more aggressive treatments, and you might still be on them, and that is completely fine. If this is not the case, you still have worsening disease activity, and you are still on these medications, maybe after this lecture, not a bad idea to discuss with your doctor, is this still the right treatment? But again, most of the time we know that these treatments are good for some patients, but for some, they are not. I'm not going to spend so much time with them because I'm sure many of the people in this room had been through many lectures about these medications, but they are typically injections. And you might remember that they are associated with some side effects. And that's why sometimes they might not be the right treatment option for some people. So that's the main reason that I was making those comments. And again, Kesimpta, we will talk about that a little bit. None of these comments really apply to Kesimpta. So let's talk about oral treatments. And again, we have got treatments here that some of you are very familiar with. Let's talk about teriflunomide, Obagio. Obagio is the brand name, but this is one of the treatments now. There are so many generic options. And also, the new treatment options are now compared to Obagio, compared to a pill. And with this, we know that, comparing to some medications, actually Obagio is still pretty good. And if you are on it, it's a once-a-day pill, so it's an easy pill. If you are just starting on it, your doctor might want to, not might, your doctor will have to monitor your blood testing monthly, because when they initially studied this medication, there were some liver injuries that honestly never happened to me, but your doctor will still need to monitor this monthly for 6 months, and then it will be regular monitoring. It's once-a-day pill, but the most important thing to know with this medication is that if you are at childbearing age and you are thinking of getting pregnant, or even if you are a man and you want to conceive with your partner, this might not be an ideal treatment, because we do know that even for men, this medication might go into your semen, and if you are a woman, this medication does stay in your system for a while, and if you want to conceive, you need to get elimination protocol from this medication. Next, we are going to talk about fumarates or dimethyl fumarate. So many of you remember Tecfidera when it was first marketed into market. It was great because so many people went on it, but it was associated with some side effects. Then a few years ago, it went on generic, and because of these side effects, by the time that it went on generic, they studied other treatments that might be helpful to avoid these side effects. And they are diroximel fumarate and monomethyl fumarate. So both of these medications are doing exactly the same thing as Tecfidera, or the dimethyl fumarate, and actually all these medications turn into monomethyl fumarate in your stomach or your intestines, and then activate it itself. So this is typically twice-a-day medication. If you are on Vumerity, you might need to take higher dose. That's why you need to take 2 pills twice a day. And if you are on these medications, you might get flushing. You might actually get gastrointestinal side effects. And that's the main promise of Vumerity, to avoid this. And with all these medications, compliance is the key. But with the next 4 that I'm going to talk about, and that will be fingolimod, sponimod, ozanimod, and ponesimod. So with these, the compliance will be really key. These are once-a-day medications. Gilenya is the oldest one that had been in the market for this, but some of you might remember, if you took Gilenya, what did you have to do with the first dose? You had to get monitored for your heart, because we realized that these medications can slow down your heart. And that's why so many researchers said wait a second, this is a good medication, but how can we exclude the heart from the picture or other side effects? And that's why they worked on the other medications. Mayzent or Sponimod was actually studied on even secondary progressive patients with active disease, and it did show some benefit, but again, these are the people with active disease, so relapsing people. Zeposia, it was actually focused on cognitive improvement or cognitive abilities and atrophy of the gray matter, and it did show some benefit with this. And good thing with the Zeposia is actually it is approved right now for ulcerative colitis. So if you have got both of these conditions, and even I know that for Crohn's disease, some of the gastrointestinal doctors recommend it. And if you have both of these conditions, this might be a great drug for you because you can kill two birds with one stone. And Pomvery or ponesimod is also a similar medication in this group. So all these medications, we still look at your heart before you start, but unless you are on Gilenya, we might not need to look at that. But Gilenya is now generic. And if you are on Gilenya, you might be on generic fingolimod, and that is completely fine. But to be honest, I'll be honest, starting Gilenya now is very difficult because we still need to monitor you, and then that support to monitor can be very difficult. So other options, I'm so glad that they are there. If you are on a medication like this and you have got side effects, they are great options. Another oral treatment here is Mavenclad, but also I'm going to exclude this from our talk right now, and I'll actually come back to it because while it is a pill, I don't think it truly belongs to this class of medications at the moment. So let's talk about infusions. So these are also immunomodulator treatments. So natalizumab, Tysabri, and this treatment, I know many of you are very, very, very familiar. When this treatment was first marketed, it was so good that so many MS neurologists thought, we treated MS, that's it, we cured it. But then what happened? We started to know about potential complications, and that was PML. So PML is an infection that can happen in your brain if this virus called JCV is in your body, okay? And we can never say that it is in your body or not, but what we can test is this one immune marker that shows us your immune system have encountered it. If you are positive, we can never say that you definitely don't have any virus, and that's why if you are positive and you take this medication, especially after 2 years, you can be at risk for this infection in your brain. But if you are negative, then we know that your immune system never encountered it, hence your body never encountered it. And with some patients, this is still a great treatment because this prevents those immune cells that create the disease from entering the brain, and it can really help with stop the disease or really slow it down. So that's why I think this is still a good treatment. There's a biosimilar that is also going to be an option soon for some people that insurance is not covering or so. So that is, I think, still a very good, very strong medication. So I'm also going to skip the Lemtrada. We are going to come back to that because again, while this is on this group of treatments, it's actually a different treatment, different medication. But let's talk about the B-cell treatments. As you know, these treatments came into market or officially studied for multiple sclerosis in 2017. However, some of you were maybe even on rituximab even before then. Why? Because we had rituximab for a while, but we didn't know these medications were working actually on multiple sclerosis. Because before 2017, before the researchers released their results, we thought that the B cells are not really taking part in multiple sclerosis. We thought T cells were taking part in multiple sclerosis. But then, just some physicians, especially in Sweden and California, started to, for whatever reason, started to treat their especially difficult patients, the patients that they really didn't have any options, they couldn't give Tysabri or similar medications. So they started to give these patients rituximab, and they realized that these patients are doing great, especially even the progressive patients. So then they actually developed ocrelizumab, which is a more humanized version of rituximab. What does that mean? When you get rituximab, you get actually a little bit animal protein. When you get ocrelizumab, that is actually really maximized for human protein, but not completely human protein. And they realized that this is actually working with relapsing remitting multiple sclerosis really well, but also it is even helping the progressive patients, primary progressive patients. We didn't include primary progressive patients when we first talked, so let's open a parenthesis here. Primary progressive patients will be the patients, and some of you might be primary progressive, that you really didn't have a relapse. You didn't lose your vision one day while you are driving. You didn't wake up with not able to move your legs. You didn't wake up with, your arm going numb. But all these things slowly started to happen. You notice that, or some of your family members notice that you are tripping while you are walking. Or you notice that, my memory is not as good. What is going on with me? If you are tripping, or you have got pain, or you have got spasms, you even first went to neurosurgeons, and they might have even operated on you thinking that this was a back problem. And then they realized that you are still getting worse. And finally, they did look into your brain and spinal cord, and they saw lesions. So very, very often with patients with multiple sclerosis that are primary progressive, we don't necessarily see large relapses. And that's the challenge with this condition, because if we don't see relapses, or we don't really see major changes on the MRI, what is really causing this? Is it really inflammation? And that's why many of the treatments that we talked about, it was studied before with progressive multiple sclerosis. And unfortunately, they didn't get the results that they wanted. And finally, ocrelizumab, when they studied this, they actually did see that with patients that are active, so with new lesions or active lesions in the MRIs, they were actually able to slow down the progression. And that's how this medication was the first medication that was approved for primary progressive multiple sclerosis. And then, when this B-cell treatment really was successful, they started to look into how can we enhance this, make it easier for the patients, because some people were having side effects, or deliver it in other ways. And then came ofatumumab, Kesimpta. Remember, I talked about this with the first slide, and I say I'll come back to this, because why? This is an injection. This is an injection that you do for yourself. It's a self-injection. It is once a month, except for the first month. You do it weekly for 3 weeks, but otherwise it is once a month. And what does it do is that it goes into your lymphatic system, and your body gets it. And this is fully humanized, so no human protein on this. And that's why you can do this even at home without going to an infusion center. And this was a very good help, because especially you might remember, this was in the times of COVID. So that's why we had difficulty with finding infusion centers, or having people go to the nurses, or having nurses go to the people. So this was really helpful. And again, with the side effect profile too, it was good. And then they actually did say, how can we improve this even more? And they glyco-engineered a protein called ublituximab, or Briumvi. And I don't know how they came up with that name, George, but it's a difficult name to say. But it is also an infusion, but because it is a very good protein that doesn't give you as many side effects, we can actually give this much faster to you. So if you are somebody especially that don't want to do needles, or you have got side effects with the other medication, this also started to help. And there were people, very small percentage of people, that were not getting the benefit that we want from them with the ocrelizumab. And then with this medication, they were also actually able to help with the B cells, or help deplete B cells. And the newest one actually in the market, some of you might be familiar, this was exactly a month ago that this was approved. And this is Ocrevus Zunovo. So it's the same old Ocrevus, or ocrelizumab that you know. But instead, they were able to combine this with a molecule that this can be delivered in subcutaneous tissue. What does it mean? This means that you can essentially have this done as an injection on your belly. This will still need to be given by a nurse or a doctor, but it will be on your belly, and it will be about 30 minutes injection. So not like ofatumumab, so once and you move on or something you can do, but it will be a nurse that will be giving this. And typically in an infusion center, you will still need to get the pre-treatment blood testing, blood work, medications, and then you will still need to be monitored. But especially if you are on either of these medications and you are a difficult stick, so you really cannot do the IV, this is a good addition too. Or you are very busy, you don't want to spend even an hour or 6 hours in the infusion center, this will be a good treatment for you as well. There are still some people that are being treated with rituximab. And again, rituximab is still doing the job too. And if you are being treated with rituximab, unless you have got side effects, your doctor might still want to keep you on, while the insurance companies might fight with it because it is not technically approved from FDA, but these are all good treatments. So now, I did mention that I was going to exclude cladribine or Mavenclad and alemtuzumab, Lemtrada a little bit in the first part because these are actually working a little bit different. So I told you that the first treatments are immunomodulators. So all these medications, as long as you take them, they will work. If you stop taking them, they are not going to work. Versus there are medications that actually will work without you taking them because they will make some changes in your immune system, and those changes are going to be much longer acting, and you are not going to need repeat treatments. And we call them immune reconstitution treatments. What does that mean is that it is essentially resetting your immune system. And the one that we are most familiar with from older times is Lemtrada. Lemtrada is an infusion that you get for a few days, and then you get again for a few days the next year. Lemtrada is a very good, very strong medication. However, what happened with patients that were treated with Lemtrada is, because it is really affecting the immune system in multiple different fronts, patients start to get other immune side effects. And your blood testing had to be monitored for years, including your urine, because we did start to see side effects on your kidneys, and we did start to see side effects on your blood. And that's why Lemtrada is still being used, but only for certain patients. And you might have your doctor have it offered to you, or you might have been treated and you might be so good right now, because again, as long as you don't get the side effects, it's a good treatment. But because this was limited, and we have got another treatment option now, and that is cladribine or Mavenclad. And this is also working in the similar mechanism, meaning that you don't have to consistently take this. You only take it for a few days, a month later you take it for a few days, and a year later you again repeat it. So what happens with this treatment is that your immune system again will have some changes. But thankfully, those changes are not going to be as aggressive as Lemtrada, so you are not going to need to get blood testing for a long time. However, one thing that if you are on this medication, your doctor will talk about is when they did the clinical trial, there was a concern with the cancer risk a little bit. And this was a very traditional trial, so the researchers thought that, this cancer risk, is it really there, or is it possible that something else might be affecting it? So they repeated the study, and they were able to show that that cancer risk is not really fully there. But again, we always warn you, we say that with all these medications, please, please, please stay on top of your cancer screening. And the last thing that I will talk about is not really commonly offered, but something that is also coming in the pipeline is stem cell. So this HSCT stands for autologous hematopoietic stem cell transplantation. And that means that somebody is collecting your blood and filtering the stem cells out of your blood, and they give you a very strong treatment that wipe out your immune system. And then, because your immune system was attacking your brain, after this, they give you back your stem cells. So this is like almost a hard reset on your immune system. And then the new cells that new stem cells are creating are going to be less toxic to your brain and spinal cord, so you are not going to get as many MS lesions. And this is a treatment that, in about 2018 that was studied, and it was able to show us, that study was able to show us that this is a good, safe option for some people, but it was only compared with the older treatments. So those treatments that we knew that already not as efficacious. And therefore, right now, there's actually a study that is looking into this treatment, comparing to the infusions or other treatments that we have, to say, is this better than what we have, or is it too risky and it's not worth it comparing to the infusions and other treatments that we have? So time is going to show what is going to happen with this. So this is again going back into that treatment that I was telling you, that some treatments you will need to do regularly and some treatments you only will need to do for a short period of time. So you see, this is not even a comprehensive list of all the MS medications, but some representation. If you are taking a pill, you need to do it every day. If you are taking infusions, especially B-cell infusions, you will need to do them every 6 months. If you are taking natalizumab, you need to do it every month. If you are taking interferons or injections, you might need to take them 3 times a week, sometimes even every day. If you are taking, again, the S1Ps, Gilenya, fingolimod, Zeposia, ozanimod, etc., you are going to be taking them also every day. Same with fumarates. But for cladribine and alemtuzumab, you only do those for a couple of times. And again, same with the stem cell transplant. So what is in that pipeline? So this is, time will show, okay? But you might have recently heard that Sanofi released a statement that their study was showing some positive results. And we are looking at the BTKI. So Bruton kinase inhibitors are a group of medications that will be able to cross the blood-brain barrier and might be able to inhibit the B cells, but also other cells that we call scavenger cells, microglia, that might be causing some progression. Because remember, I told you all these great medications, but remember in the beginning of the presentation, I told you, unfortunately, we are very good at treating relapses, but unfortunately, we still see patients slowly get worse. So how can we help with this? And we still don't understand why that happens. Why are patients still slowly getting worse? But we think some of the reasons might be because of those scavenger cells or other things. So that's why these group of medications have been studied. The first medication in that group, they only looked at the relapsing part, and it didn't outperform a comparator, which was Buse, which was the oral pill that I told you. That means that it is still working on the relapses, but not much better. And then they looked at this medication, tolebrutinib, and they focused on both the progressive patients and relapsing patients. Same story with the relapsing patients, it didn't necessarily outperform, but with the progressive patients, it did, at least the first preliminary studies, and this is still a limited information that we know. A month ago, they told us that they actually did show that patients did not progress as fast. And there's 2 other treatments that are in the market. One of them is still looking into relapsing. We will see if this is going to fail, comparing to comparator again. But they're also looking into this in primary progressive and comparing with actually Ocusys, the fenobarbital. And we are going to see if this medication is going to be able to outperform the primary progressive multiple sclerosis. But truly what we really need is a remyelination treatment. And you might remember there were so many remyelination treatments that were in the pipeline. Unfortunately, they did not give the results that we wanted them to give. Now there are clemastine or similar molecules that are being studied, and because of the way that myelin structure is, they are looking into these products. Clemastine, you might be familiar with that. It's a treatment it's an anti-allergic treatment. So it might still make people a little drowsy, and that might be a big limitation. I know many of you deal with fatigue in day-to-day life. So that's why they produce new products that maybe has a little bit less fatigue or that, sleepiness effect, so they are going to look into them. And another treatment that if you're a patient of mine, I might have talked to you about this, is alpha lipoic acid. And this is just a vitamin. They did an initial study and they did say that patients maybe didn't progress as much. There's a bigger study, a little better study that is going to look into this, but I think it's a vitamin that is unlikely to hurt, so I might have given that to you. And hopefully we will know more in the future if this is really working or not. I think I'm perfectly on time, so I think we are ready for questions.
Thank you. Hi, thank you so much for the presentation. I know that you mentioned that the stem cell treatment isn't routinely performed, but I was just wondering if you could give us some information about who is eligible. So what, maybe symptoms or requirements are needed for someone to be considered for the stem cell treatment.
Yeah, very good question. So as you might have heard, there are so many centers, especially out of the country, that claim that they do stem cell treatment. And unfortunately, we don't know the quality. I've seen this being, to be honest, nothing. Like, they don't actually treat you because there's no higher, organization that really control this. Or I've had some people that get good treatments abroad and they have a stable disease. But in the US right now, this is only certain centers that are able to do it. Why? Because actually this requires a partnership with hematologists typically and an MS neurologist. And also another thing is that because this is not yet approved is the insurance coverage, because sometimes insurance might not cover this. And again, we are talking about actually pretty aggressive treatment. We are talking about potentially significant infections. I know that in the early treatment results, there were even some patients with significant blood clots, especially if you are a woman at an age that you might want to get pregnant, that might also affect that significantly negatively. Before we know if this is better than the treatments that are available, right now, there are people that I have referred to the centers with the stem cell treatment. I know in very near future, University of Miami might start the clinical trial with that, and I'll see what that clinical trial or the center, what it will look like. But right now, we typically look at this with people that really don't benefit from the available treatments or as part of the clinical study.
Yes, hi. I'm curious, are there any studies going on right now to determine if there are any age groups that can stop taking treatments?
Age groups what?
That can stop taking medicinal treatments.
Very good question. So actually there was a study. The results were not as detailed as we had hoped, but we were really hoping that this was going to answer the question, called DISCO-MS. And in this study, they actually randomized people over the ages of 55, and they randomized and said, okay, based on the flip of this coin, you are going to stop versus you are going to continue. And they said after those results that the relapse rate was about 7 to 10%. But again, this was including from 55 to 75, I believe, so large group of people. And in my daily practice, what I do is, especially if a patient is very stable, interested in stopping treatment, I might offer them this, especially after the ages of 60 or 65, but with very, very close monitoring. I typically even do MRIs every 6 months, and this was the protocol of that study too, so that's where I got this idea. And I monitor them very, very closely to make sure everything is good. There's always a risk for relapse or worsening, so of course this requires a very good discussion between patients. But in Florida especially, we really need that question answered. How can we really treat the older people very adequately? And older is not even the right term in 2024, because we are talking about after the ages of 55 that some clinical studies are not even including, and this is not right.
Hello. You said the alpha lipoic acid, there's been studies on that. What milligram strength was used in the study that showed effectiveness?
In the study, so the first study wasn't that comprehensive, so it wasn't done in a good way, but they use 600 milligrams twice a day. What I typically advise is taking 600 milligrams once a day. Unless you have got any gastrointestinal side effects, you can take it twice a day.
Thank you.
Hi, Dr. Sengul. How are you? Since we take this DMT to suppress our immune system, I wonder what happens if we, on the other side, we take a lot of supplements to enhance our immune system, or vitamin D, or turmeric, or other antioxidants. What is the effect of these I don't know.
Yeah, I got you. So very good question. So again, because we don't want your immune system to be very effective, unless you have got a lot of infections, we typically don't want to give you a lot of supplements. And the other reason for that is, as you know, supplements are not tested as detailed way that the many medications are. And that's why we don't know the interactions and everything. However, the ones that you are talking about, vitamin D, we always recommend, because vitamin D is really studied very, very, very detailed in multiple sclerosis. We know that even increasing vitamin D 10 points is going to really decrease your relapse rate about like 30%, but we don't really have any comparison with the treatments, but it's a very good option, and it will even help you with the symptoms. So that's why we like the vitamin D. Turmeric, a lot of people use it. I really don't have any objections. I haven't seen any interactions. I don't think it enhances the immune system to a point that we don't want it, so I do recommend that too. And the other supplements that might help you, like CoQ10 and so forth, I also like them too.
For Mavenclad, what's the target and the mechanism, and is it used in primary progressive?
Very good question. So I'll go a little detail since you asked this. So essentially, Mavenclad goes into your lymphocytes, and it affects the DNA synthesis in those lymphocytes. Only goes to the lymphocytes, no other tissue in your blood. Mavenclad or cladribine, the first treatment, is actually approved for certain type of lymphoma. So it is very good at depleting those lymphocytes. And that's when the researchers start to say, lymphocytes are working on multiple sclerosis. Is it possible that we can use this treatment, not the same dose as we use it for, lymphoma, so much, much, much more diluted dose, and can be really helpful with MS patients. I know that there's a study that is looking into primary progressive MS and Mavenclad, but right now it is not approved for it. We don't know if it helps for it or not.
What are the precautionary measures that a woman should take when having to get pregnant, during pregnancy, and after pregnancy to not have a relapse?
Very good question. So traditionally, we used to use glatiramer or Copaxone for our patients that wanted to get pregnant, because that was our safest option. However, now we know B-cell treatments are also greatly safe treatments. And especially ocrelizumab is really studied very, very widely. They have got many patients that they put in their databases, but I know that other B-cell treatments are probably good as well, but they are not studied. I mean, of course, ocrelizumab had been in the market for farther long, and that's why it was studied much longer. But it's a great treatment for pregnancy. Typically, what I advise for my patients that really want to get pregnant, I don't like the option of giving them Copaxone because it's not as good treatment. And pregnancy, before pregnancy starts, while pregnancy itself can be protective, we want to make sure that we really get you, or we can control the disease. Especially somebody really, really aggressive, I might even ask them, can you please hold off for a few months so I can control your disease a little bit better? Again, as a woman, I know that sometimes it can be okay to delay a little bit, but I know some of my patients really want to get pregnant soon, and that's why ocrelizumab is a great option. Typically, what I tell the patients is that get the infusion. We used to say that wait 3 months because that's when the drug is completely out of your body, but now we know that actually, because first couple of weeks in the pregnancy, you really don't have that blood transfer from the mother to the baby. That's why I even tell the patients, conceive. If they conceive, I don't treat them during the pregnancy. and because you are protected. And after the delivery, typically between 2 to 4 weeks, I give them another treatment because also we know that ocrelizumab is very good at breast milk, so it does go into breast milk, very negligible amount, but it doesn't, even then, it doesn't go into the baby. So that is a great treatment. Again, other B-cell treatments might be used, and some of the doctors might be comfortable with that, but that is the one that is studied the most.
Hi, doctor. I wanted your opinion on Ocrevus. My husband is doing the Ocrevus, the infusion, on what happens if when it's time to do the infusion again, the B cells are totally depleted. Should he do the infusion anyway or skip until, or when will he do that infusion again if you keep doing the blood work and the B cells are still depleted, continue to be depleted?
Very good question. If you were to ask this question in a big conference with a lot of MS doctors, you are probably going to get 50% different response from everybody. Because we still don't know. But what I like to do is, and this is something that we were very worried during especially the COVID pandemic about treating patients much more often than we would want to. And that's why we started to delay some patients. And in my experience, there were some people that the progression might have been a little bit faster, even though they did not have B cells. One thing that I'm concerned about is that B cells, when we check them, we can only check them in the blood. We cannot know the level in the other areas, like in the brain or bone marrow and so forth. And that's why I don't like to wait too long unless there's a major safety concern. That means infections or other complications. And if that is the case, I even have patients that I like to monitor their blood testing and give them as least infusions as possible.
Yes, hi. Hi, doctor. I have a question for you. It's a little bit of a different level question. In the current days of AI and precision medicine, have you heard of personalized peptides for active disease and resilience? I know it's investigational, so obviously, FDA has not involved in that, but I want to know if you've heard of research coming through really, because I've been reading research where peptides are being used to help treat cancer patients, spinal cord injuries, multiple sclerosis, autoimmune disease. And I asked my own neurologist, and she's like, oh, well, I don't support any of that. I'm not, And like you said, different neurologists will give you different answers. And I don't know if you have heard anything down the pipeline regarding promising treatments using peptides for MS.
Sure. Yeah, very, very good question. So the answer is I don't know. But I really do believe that AI is going to help us a lot, used in good ways. And we actually had a symposium only a couple of weeks ago about AI and neurology, how it is going to help. And even like some of you that come to see me in the clinic, I might have told you, I'm not going to be typing because I have now AI help. So I'll put my phone and our notes are going to be written so I can focus on you. That's like one of the good helps. But about the treatments and clinical studies, I'm really helpful. I think it is going to eliminate some of these treatment trials that we have that don't necessarily result in a positive way. And even with just like you said, in cancer treatment or other things, there are so many advances, not in MS world that I'm aware of, but the field is growing so fast that I'm sure maybe even next month we might hear some new things.
So back to the B-cell depleters. Among that group, which is less likely to cause infection? And the second part of my question is, do any of them work on PIRA?
Okay, very good question. So the second part of PIRA, we don't know, again. If you look at the studies of like people even being treated with them for a long, long period of time, you can see that comparing to those people that weren't immediately started, the gap is big, right? Like those people that were even treated as part of the clinical study for like 2 years with now B-cell treatment, and they are still more disabled than the people that were treated with. So I think it might be helping, but our evidence for that is really limited, and especially with the fact that it is not really crossing the blood-brain barrier. Many neurologists are thinking that that is one of the reasons that help is not great. But unfortunately, it's very difficult to know because PIRA can be affected in so many, and PIRA is like progression independent of disease activity. Some of you guys know this, that you might be getting worse or some symptom might get worse. Even though everything is good, your doctor is saying your MRIs are great, everything else is great. So I think we really don't know if it really helps with PIRA or not, but that's the best option that we have, so we still use. And the first question was, is any of them better with the infections? So unfortunately with the infections, we can only look back and see how many infections that people get in certain amount of time. And of course, the first treatment with the ocrelizumab, there are so many patients, you are likely to get a bigger group of people. However, one of the experiences that many people will say, I do think that immunoglobulins can be depleted a little bit more with ocrelizumab comparing to the newer options like ublituximab or ofatumumab. So I think the new treatments can be tiny bit better in terms of the infections, but to be honest, I cannot tell you if this is a big, major difference.
Hello, Doctor. Nice to see you. I wanted to ask about the Ocrevus. You're saying that there's a newer version of them, which is a different delivery system where it's subcutaneously in your tummy. Is that the one that you take every month now?
It's still every 6 months.
Okay. In the UK, they're administering Ocrevus monthly, and you can do it at home now. Do you think we're going to get that here? And the reason I ask that is my husband takes the Ocrevus, and the drug has worked really well for him. He doesn't get any adverse side effects, so we're really happy about that. But the one thing is that when you're getting to like month 5, they call it the crap gap, don't they, where you start to deteriorate. And then as soon as he gets his next injection, he starts to feel better immediately. So my question is, are we going to be able to get that monthly injectable in the USA so that you'll then avoid that crap gap? Or as his doctor, are you able to say, well, instead of every 6 months, you can have it every 5 months, for example?
Yeah. So I did have some patients that I did fight for infusing every 5 months, and it did work. But unfortunately, it is very insurance dependent.
I'm sure.
And comparing to before, I think it can be, especially if the doctor can show the effects of that, I think it can be an option. But again, really up to the insurance company. The monthly infusion that you are referring to is probably Kesimpta, the ofatumumab, and it is an option that I do refer to my patients, especially if they do get that crap gap closer to the time, and it can be an option, or the other medication, ublituximab, Briumvi, can be an option that maybe those people might also have less crap gap. The new treatment, the injection, is also going to be every 6 months, except that with this, you don't need to split the dose the first time. It can be just given every 6 months.
And then, second part of the question is...
You're only allowed one.
Sorry, I'm making the most of it as I'm here. You don't often get the doctor in front of you who's going to ask, well, it's good, it's a great opportunity that you've come, thank you. And can you combine 2 medications together? Because like the Ocrevus targets one particular aspect, but then there's other drugs that target another part. Is there a combination? And also, you mentioned that alpha lipoic acid, that as a new thing. Can you have that in conjunction with Ocrevus as well? Would we come to you, or you would suggest that as an additional?
I think you can have alpha lipoic acid in any case, even if you are not taking any medications, even if you are taking a medication, it's just a vitamin, unless it is causing any problems, which typically it doesn't. Some people might have some stomach upset with that, but otherwise I haven't really heard any major complications. One of my patients had slight elevation in the kidney functions, then we had to stop. So that is the second part, that is the easier part. About like combining treatments, we do not. But we do not because there were early trials that looked at the two different treatments and combining them and then said, it doesn't really help the patients. It is not more superior than just one treatment and the side effects were a little bit more. That is the reason that we do not combine. But you are very right. And I know that so many people still talk about this, that, because we looked at this far long ago, and now that there are some medications that might not be really effective for the relapsing disease, but it might help with the secondary progressive disease, especially the new treatments. So is it possible that we might revisit that? I don't know. But right now, we only want to treat you with one medication to make sure that we are avoiding any risks or, complications.
Thank you. Is there an expected timeline for BTK inhibitors?
Very good question. I don't know. If I had known, I would have put my stock money on them, but nobody knows. So, and this will also depend on with the BTK. When the clinical studies were made, there were some concerns with the liver function levels being a little elevated. So that's why I think it will be a little bit negotiation with the FDA, how they can monitor what is the proposed mechanism and so forth. So we will see.
Okay, thank you. The next one is there a benefit to taking Ocusys on a short-term basis, like just a year?
I think a year is too short for us to determine if this is working or not. I think 2 years is a little bit more objective, just based on my experience. I cannot really tell you that, this is based on any clinical study or not. Nobody really studied, but I think if somebody wants to do it for a short period of time, and see if it is helping or not, I would do a little longer.
Okay, thank you. Next one is, what's your opinion on hormone replacement therapies to reduce progression?
Oh, very good question. So I wish I also had an answer for that. We have so much data, especially on women, how, like, for example, menopause can affect your brain from just even without MS, right? Or like in terms of aging, dementia, memory problems, and so forth. So, and we know that with MS patients, that those people that ended up getting, let's say, hysterectomy for any reason, the decline can be fast. So I do think that as long as your gynecologist is allowing, based on all this data, I think it's not a bad idea to discuss this, the hormone replacement, because again, there's no major data, unfortunately, even with those people that we know, very limited, but I think there can be a benefit. So unfortunately, we didn't do a good job in thousands of years of having women around us and studying menstruation and, menopause. So hopefully in the future, we will have more information about this.
Awesome, thank you. Last one online is, what is the likelihood of using stem cell therapy in the future for progressive forms of MS?
They are also, I don't know if there's an active study, but when I was talking to some researchers that are working on the stem cell, I know that they were looking into especially secondary progressive patients and even primary progressive patients, but I don't know when we are going to see any results yet.
Everybody, let's say thank you. Not yet. All right, here we go. We have a plaque for you to put up in your office, all right? And we have somebody here to take a picture. Perfect, thank you. Thank you very much. Thank you very much. Thank you for taking part of your day up. Awesome. Be safe, everybody. Do what you got to do in life, all right? Don't let MS stop you. Don't let MS stop you. Take care. Have a great day.